Good morning. I'm Eric Linzer, President and CEO of the New York Health Plan Association. Welcome to Day 3 of HPA's annual conference, Decision 2020, What It Means for the Future of Healthcare. We're excited to have you back with us, and we've got a great set of speakers lined up for today, and we're looking forward to the discussions. Now, yesterday we had a series of 3 great panel discussions. We kicked off the day with a discussion around addressing the opioid crisis. Courtney Hunter from Shatterproof joined us to talk about the challenges in bridging the gaps between evidence-based care, practice, and policy, followed by a panel discussion that included Senator Peter Harcum, Kelly Hansen, and Dr. Angelia Smith-Wilson. We then looked at states' efforts to curb prescription drug prices. Joel Menges joined us to talk about efforts that states have undertaken to get healthcare and prescription drug costs under control. And we were joined by a panel discussion that included Assemblymember Daniel Rosenthal, Beth Finkel, and Trish Riley. We then concluded the day with a panel discussion looking at maintaining momentum around payment reform in the midst of a pandemic. Andrea Caballero from Catalyst for Payment Reform joined us to talk about efforts and how the progress is going around value-based payment arrangements and what some of the challenges are in the face of COVID-19. Dr. Toyin Ajayi and Dr. Lori Zephyrin joined us, and we had a really great panel discussion. If you weren't able to join us, all of these sessions, plus the sessions from day 1 of the conference, have been recorded, and their links are up on the conference platform. Today, we have 2 great panel discussions to finish out the 2020 annual conference. Our first is going to take a look at the key features and performance of Canada's tax-funded healthcare system and the issues and challenges facing patients, providers, and payers. And then we'll conclude our conference with one of my favorite panels, our view from the marketplace. This gives us an opportunity to hear from folks who represent consumers, employers, and unions who are dealing with both the economic and public health challenges that 2020 has brought us. Now, before we get started, just wanted to once again thank our sponsors who've really helped make the last couple of days possible. In particular, I wanted to thank our Diamond level sponsor, Pondera Health Solutions, and our Platinum level sponsors, Liberty Dental, Envolve, and Omada Health. I also wanted to encourage you one last time, if you haven't already, to make sure you check out the exhibitor booths. And as a reminder, we've got the gaming challenge going on. As you'll recall, as you go to each exhibitor booth, there's a 4-digit code embedded into the description of each of the exhibitors and sponsors, and then you enter that into the game challenge. We've got a tight leaderboard for this year's gaming challenge. We've got about a dozen people atop the leaderboard. So as we've mentioned, while we've got some great prizes, including first place, a $250 Amex gift card, second place is going to be a $100 Amex gift card, and third place is going to be a $50 Amex gift card. In all likelihood, we're going to be having to hold a drawing later this afternoon. So if you haven't gotten your points yet, now's the time. So with that, I'm going to turn the controls over to Don Ingalls, Vice President of State and Federal Relations for Health Now New York, who will introduce and moderate today's first discussion, Understanding Single Payer, Lessons from the Canadian Health System. Good morning, Don.
Good morning, Eric and everybody. Very pleased to be with you this morning, coming from Buffalo. And it's my pleasure to introduce our next panel, which is to moderate this morning's session. We have 2 presenters today, excellent researchers, Bacchus Barua and Steve Globerman from the Fraser Institute, which is an independent, nonpartisan research and educational organization based in Canada. It is the top think tank in Canada and ranks in the top 15 among all think tanks worldwide, according to the 2019 Global Go to Think Tank Index published by the University of Pennsylvania. It's really great to welcome Bacchus Barua, the Associate Director of the Fraser Institute Center for Health Policy Studies. He has conducted research on a range of key healthcare topics, including hospital performance, access to new pharmaceuticals, the sustainability of healthcare spending, and international comparisons of health systems. He also designed the Provincial Healthcare Index and is the lead author of the Fraser Institute's The Effect of Wait Times on Mortality in Canada and Waiting Your Turn, Wait Times for Healthcare in Canada, 2010-2019. Joining Bacchus is Steve Globerman. Steve is the resident scholar and Addington Chair in Measurement at the Fraser Institute, as well as Professor Emeritus at Western Washington University. Previously, he held tenured appointments at Simon Fraser University and York University, and has been a visiting professor at the University of California, University of British Columbia, Stockholm School of Economics, Copenhagen School of Business, and the Helsinki School of Economics. Welcome to both of you. It's really a pleasure to have you both with us, and through the miracle of modern technology and our friends at Socio who are connecting us all, Bacchus is coming to us from Vancouver, and Steve is coming to us from Bellingham, Washington. I'll turn it over the session to Bacchus before we get into the Q&A portion of today's session. Bacchus?
Thank you so much, Don. We are so grateful to be here to try and share what we know about Canada's healthcare system. Thank you for that kind of introduction. You know, healthcare is a remarkably emotionally charged topic, and it's very difficult to have objective conversations about healthcare. Everybody has a personal story that's, you know, either positive when a life is saved, or negative when that's not the case. And it makes it very difficult to actually talk about the performance of a healthcare system and, you know, potential for reform. Canada in particular often tends to get dragged in by the media and either is, you know, painted as the socialist scourge or, you know, a healthcare hero. And what Professor Globerman and I wanted to do was to try and provide our best understanding of Canada's healthcare system, how it actually works, and how does it really stack up compared to other countries around the world. As you mentioned, we both work at the Fraser Institute, and thank you for that that introduction. To that, I just want to add that all of our work, and a lot of which is coded over here, does go through a codified peer review process. We don't accept any government contracts for research, and all of the information that you'll see is public information that you can access for free on our website. So with that, let me start. In general, what we wanted to do was we wanted to try and look at 4 different areas during this presentation. The first is just you know, provide an overview of the policy environment in Canada. What do things actually look like on the ground, and why do they look the way that they do? The second is that we're going to look at, well, okay, once we understand the healthcare system, how does that actually compare to other countries around the world? If we have some time, we'll take a brief look at pharmacare and some of the push being made towards a national pharmacare system in Canada and some of the consequences of those moves. And finally, we'll end with the discussion of, you know, some of the major issues that are often brought up in terms of the legality of the current rules and the current systems, issues to do with the fairness and equity when it comes to private versus the public sector. And finally, looking a little bit about how the advent of technology, including what we're doing right now, may seriously cause a lot of reconsideration of what the rules are on the ground. So with that, let's start. You know, it's always useful to start with a basic understanding of what the spending structure looks like in Canada. Despite being often called a free healthcare system, we actually do spend quite a lot on Canadian healthcare. These figures are in Canadian dollars. We're spending about $260 billion on healthcare every year. At the last estimate, that's about $7,000 Canadian per capita, and that amounts to about 11.6% of GDP. In general, you can see when we look at the public-private split, there actually is about a 70-30 split, which is, again, quite different than the way Canada's healthcare system is often characterized as a purely public system. That being said, the public system does account for a very large portion, about 172 billion at the last count, or about $4,600 per capita. I included this slide just for a quick comparison. I don't propose to try and tell our attendees about the American healthcare system, because they, of course, probably know it far better than I do. But as you can see, there are some very obvious differences between the Canadian and the American healthcare systems. But both, you know, painting Canada as a purely public system and United States is a purely private system is potentially inaccurate. So again, I'm not going to go into the American healthcare system, but I do want to talk about that big blue slice of pie on the Canadian side, and actually look at, well, what is the Canadian public healthcare system? In order to do that, it's generally characterized, I would say, that that slice is that it provides universal coverage for medically necessary services, and that's a very specific and important term that I'll talk about a little bit later. The 70% is really a tax-funded system that provides coverage, first dollar coverage. That essentially means that patients don't have to actually pay or are subject to any co-payments when they actually receive services. However, of course, we do pay a significant amount through the tax system. We don't have earmarked healthcare taxes. It's taken through general revenues, and that actually makes it very, very difficult to try and quantify what is the true amount that Canadians are paying for healthcare. One of the things that we do at the Institute is we try to look at, understanding what the total expenditures are and understanding what the total tax burdens are for different families. Our best estimate is that for the public system, the average family of four last year spent about $14,500, and that the average individual spent about $5,000. Now, some people can look at it and say this is a very high number or a very low number. But one thing's for clear, it's not a free healthcare system, and we really need to stop referring to it in that way. Two other small notes about how the healthcare system works. We do have a gatekeeping system. Essentially, that means that in order to see a specialist, you need to get a referral from a general practitioner first. And there are little to no private options for medically necessary services. Again, a term that is important, but I'll explain very shortly. In order to understand why that our healthcare system looks the way that it actually does, we have to first understand the Canada Health Act, the CHA. It's important to know that Canada's healthcare system, well, healthcare is actually generally a provincial responsibility according to the Constitution of Canada. That being said, towards the late 60s, a lot of different provinces started to implement universal systems of their own, and in sort of evolutionary way, that culminated in most provinces having some form of universal healthcare system by the early 80s. In 1984, we had what was called the CHA that was implemented, and it's important to remember that the Canada Health Act is not a personal act. It doesn't look at personal rights or freedoms, but it does, however, sets the conditions and terms that provinces and territories need to meet in order to receive federal government funding through the Canada Health Transfer. What does that mean? That means that even though healthcare is a provincial responsibility, the federal government exercises a lot of control through their spending power. And that's done through what are called CHT payments, Canada Health Transfer payments, which amounted to about $40 billion in transfers to provinces last year, which accounts to approximately between 20 and 25% of provincial healthcare spending. So a lot of influence is exercised by the federal government that essentially encourages provinces to adhere to certain characteristics, lest they be penalized by financial penalties. So let's look at what those characteristics are. Essentially, there are what are called the 5 principles of the CHA. That's public administration, comprehensiveness, universality, portability, and accessibility. I'm not going to go into deep details about this, but to just give you a general idea, essentially, it outlines the fact that the insurance plan of a province must be publicly administered on a not-for-profit basis. It must ensure all healthcare services provided by hospitals and medical practitioners. That's a comprehensiveness. It must provide it to 100% of insured persons on uniform terms and conditions. The insurance plan must be portable in terms of it must cover temporary leaves in different provinces and expenses that might be incurred. And there mustn't be any minimum residency impositions more than 3 months if somebody transfers to a different province. They have to be automatically covered by that provincial plan after a 3-month period. The big one, however, is the accessibility portion, which essentially says that the health insurance plan of the province must provide insurance services on uniform terms and conditions on a basis that does not impede or preclude, either directly or indirectly, whether charges made to insured persons or otherwise reasonable access to care. And that really causes a whole lot of issues in terms of what is allowed and isn't, partly because it's not clearly defined. In fact, all 5 of these principles are remarkably vague. And while that, might be viewed as providing flexibility, what it actually does is it provides a lot of uncertainty with regards to what provinces can and cannot do. And this leads to a very risk-averse environment where, provinces are essentially, for fear of incurring a financial penalty, often go much further than what's required by the Canada Health Act. Because if a particular federal government minister, healthcare minister of the day, suddenly determines that something does contravene any of these 5 principles, according to their reading of what's going on, they could incur a full financial penalty. What is, however, perhaps more well stated are what are called sections 18 through 21. These sections essentially outline essentially prohibitions on extra billing and user fees for medically necessary services that share the cost with the public system or are entirely funded by the public system. These are non-discretionary sections, which essentially means that if these if there is extra billing and user fees that is recorded and reported, the health minister does not have any discretion and has to withhold a dollar for dollar amount to the degree that that these fees have been recorded. Okay, so a lot of this, I've talked about all of this applying to medically necessary services. Again, with the vagueness, there actually isn't a standard definition of what medically necessary services are. A lot of the portions of the Canada Health Act do refer to physician services, hospital services, and inpatient drugs delivered inside hospitals. And these are generally understood as medically necessary services. There's a bit of a gray area when it comes to lab services and diagnostic tests. But what's also important is what's not included or what's not specified under that medically necessary package. And these are things like vision and dental, cosmetic or plastic surgery, outpatient drugs, psychologists, and again, there's a gray area when it comes to psychiatrists, rehabilitation, and virtual care. So that's the reason why healthcare looks the way that it does. Let's look at what are some of the key features that come out of those sort of those laws. The first is that when we look at the role for private insurance, it's minimal to absent when it comes to medically necessary services. In fact, a recent study that Professor Globman did found that Canada is unique in effectively prohibiting any primary or secondary insurance for medically necessary services. And this particular slide is interesting because this is actually in comparison to other countries with universal healthcare. So Canada, not just has a universal healthcare system, or is not unique because it has universal healthcare, but it is quite unique in the way that it actually structures its universal healthcare system. That being said, about 2/3 of Canadians have private insurance for complementary services. These are essentially non-medically necessary services that we talked about above. Okay, hospitals are technically not-for-profit entities. However, they are effectively public institutions. And that's not just us saying it. If you even look at the OECD, they actually classify almost all of the Canadian hospitals as public entities. That's because hospitals are essentially funded by global budgets. This funding is negotiated with provincial healthcare ministers, and they have very little control over the amount of services that they can actually deliver because they're subject to these global budgets, because we have essentially a sort of a single payer system. That being said, we do have some private for-profit clinics. These are clinics that provide services that are often in those gray areas or provide day surgeries. And we have some limited third-party contracting where some provinces, some reform-minded provinces have started contracting with these for-profit private clinics to try and shorten the wait times that we see in Canada, which again, we'll talk about a little bit later. There aren't huge implications for the way that physicians are funded, although of course the total amount is constrained indirectly by those global budgets. Most physicians are funded, remunerated through fee-for-service arrangements. This is more true for surgical specialists and less true for family doctors. But one of the indirect results of the CHA is essentially that physicians, there's no dual practice in Canada. You have few to no physicians who practice in both the public and the private sector. And that's not specifically required by the CHA, but it is a huge implication. And again, this goes to the risk-averse attitude that a lot of provinces have, where they've actually implemented provincial laws to prevent dual practice lest they accidentally or lest they're reported to have contravened any of the CHA's principles. And in fact, there are also disincentives to simply opt out of the public system as well. So when we take all of this together and when we understand the Canada Health Act, and we also understand the notion and the concept of medically necessary services, we get a very different picture of the 70-30 split. When we look at hospital spending, it's almost entirely public, 90%. That's even more true when it comes to physician spending, that's 98%, that's public. But it's not so true when it comes to drug and pharmaceutical spending, where it's actually mostly private. So, while my hope is that this provides a better understanding of the policies on the ground, but also to change that picture where we talk about it as a purely public system and actually talk about it, okay, not only is it not purely public, it is a 70-30 split. And that 70-30 split looks very, very different when you look at hospital and physician spending, which is almost entirely public, and when you look at drug spending, where it's not so much the case. So with that, with hopefully a little bit of an understanding about the background of Canada's healthcare system, I'm going to turn it over to Professor Kloppen.
Thank you very much, Bacchus. Great overview of the structure of the Canadian healthcare system. I'm going to talk a bit about performance, and in doing that, we're going to be looking at international comparisons of performance, and that's going to include wait times when I'll give the stage back to Bacchus. So next slide, please. So in looking at performance, what do we want to compare? We thought with the US audience, it's useful to have some metrics that compare Canada to the US, but more generally, we want to look at Canada's performance with respect to the OECD countries. And these are 37 countries that are by and large high income countries, by and large universal insurance coverage, but certainly differ in terms of income levels. And that's relevant to note, as I'll emphasize in a minute, because it qualifies the comparison in particular ways, particularly when you look at spending and you look at outcomes. So next slide, please, Bacchus. So what's the comparison going to look at? Well, first we're going to look at spending, because certainly being in the US, a large part of the debate about changing the healthcare system references spending and the high spending in the US relative to other countries. So we'll take a quick look at that. But of course, spending isn't the whole story. What do you get for spending? When we're going to be looking at a number of metrics, availability of resources, quality of the outcomes, and then access, timeliness of treatment, or what we call at the Fraser Institute, the wait times. So next, Bacchus, please. For many people debating this in the US, this particular overhead, in some sense, is the story. It looks at spending as a metric of how efficient the system is, the healthcare system is. And what we can see is when you look at spending as a percentage of GDP, or you look at spending per capita, the US spending is substantially exceeding every other country within the OECD. I want to highlight Canada in this context. Canada spends more than the average OECD country, whether it's a percentage of GDP or per capita. And here I want to reference back to the point I made just a minute ago. Some of the countries in the OECD include Colombia, Greece, Turkey. These are relatively low-income countries. And therefore, you wouldn't be surprised to find that they spend a relatively small share of their income on healthcare, because healthcare is what economists would call a superior good, meaning that as countries' incomes go up, generally a greater percentage of income is spent on healthcare as income goes up. So what can we say from this slide? Well, by the same reasoning, the US is the wealthiest country in the OECD, and therefore all other things the same, it wouldn't be surprising for the US to spend a higher percentage of its GDP on healthcare or have a higher spending per capita on healthcare. But again, back to Canada, because that's our main point of reference. Canada is certainly not one of the low spending countries in the OECD. It is an above average spender on healthcare, and therefore it's reasonable to ask, well, okay, does Canada get above average performance in terms of both access to healthcare resources and outcomes? And so let me say, just before I move on to the next slide, that another caveat that has to be kept in mind when you look at spending as a metric of performance is that this is not equivalent to efficiency, even though some people might like to say it's a measure of efficiency. The population has a certain health status, which may be independent of healthcare spending, and the US, as an example, has, for example, more drug problems, road accidents, gun violence, et cetera, which ultimately may appear as healthcare spending, but you'd hesitate to say that it's a measure of inefficiency of performance. The other point I would make, and I'll get back to this when we talk about pharmacare and Canada's policies towards drugs, the US spends as a share of income much more on pharmaceuticals than other countries. And that's primarily because other countries have price controls for drugs, and they can afford to have price controls for pharmaceuticals because the US spends the bulk of the R&D money that's done for drug development. And things might look different if everyone carried their proportionate share of R&D. Okay, Bacchus, next slide, please. So this is really setting up the next part of my discussion, which is to say, really focusing on the question, the bottom question, what do Canadians receive for their spending, both in terms of access to resources and healthcare outcomes? So let's go to the next slide, Bacchus, and look at some measures of access to resources. And on the left, you see physicians per thousand population, and on the right, hospital beds per thousand population. And what we can see if we look at the OECD average compared to Canada is an underperformer in both of those measures, i.e. Canada has a smaller relative number of physicians and a relatively smaller number of hospital beds per thousand. In the question and answer period, we might want to discuss why that is. But I would also note that the US is relatively low on those measures as well. Next slide, please. So this looks at physical capital, MRI units per million and CT scanners per million. And again, we see if we compare Canada to the OECD, Canada has a below average number of MRI units per million and a below average CT scanners per million. And here I would say that the fact that there are a few relatively poor countries in the OECD average actually makes Canada look better than it should, because if we took out those poor countries from the OECD sample, the difference would be even greater, i.e. Canada would be an even poorer performer on those two metrics. US, as you can see, is well above the OECD average on those physical units per capita. Next, Bacchus, please. So this is now looking at more at performance rather than availability of inputs. And we're looking at infant mortality, and we're looking at diabetes amputations. Canada is above average compared to the OECD on both of those. And I think the theme that's going to emerge in my discussion in this section is that Canada's performance is mixed. Previous overhead showed Canada lagging the OECD in accessibility to resources. Here it looks as though Canada is doing a little better than average for the OECD countries. But again, caveat, there are some poor countries in that OECD average, low income countries, which would make Canada look better relative to the average.
First, Steve, I'll just jump in. The slides over here, the rankings the other way around. So with infant mortality, it's actually higher deaths and higher diabetes related amputations, which is actually worse.
Yes,
sorry
thank you, Bacchus. Thank you. So let's look at the next one. Hemorrhagic strokes. This is 30-day in-hospital mortality and ischemic strokes on the right. Here we have Canada being higher on the left side and no statistically significant difference on the right side, the US being lower on both. Again, a quick summary would be, doesn't look like Canada's an outperformer on average. If anything, looks about the same. Next one, Marcus. So this is heart attack mortality on hospital mortality on the left side, treatable mortality, age standardized rate on the right side. I'm going to draw attention to the right side because in many cases, this particular metric is taken to be if you have to choose one metric to measure overall performance in the healthcare sector, I often see this one as the one that gets the most focus, and treatable mortality rate per 100,000, Canada being below the OECD average. So let's finish this up, Bacchus, with a look at oncology. Next overhead, please. Colon cancer survival rates, breast cancer survival rates. Canada looks reasonably good on both relative to the OECD average. And in a minute, when Bacchus shows you the wait times, oncology actually looks pretty good. Cancer treatments in Canada seem to be they seem to perform pretty well compared to the OECD average. The US, of course, looks good on colon cancer survival rates, less so on breast cancer survival rates. So that's the that's the measure of performance. I'm going to turn it over to Bacchus to talk about wait times.
Thanks so much, Steve. As we can clearly see, when it comes to performance, Canada ranks as one of the highest spenders amongst the OECD countries, but doesn't really get the same in terms of availability of resources, and has at best a mixed performance in terms of clinical outcomes, better on some indicators and worse on others. But where Canada performs particularly poorly, just like it does often with resources, but in contrast to most of the other universal healthcare countries, as well as the United States, are wait times. So this is some data from the Commonwealth Fund, which does surveys every couple of years across countries, and it's probably the best indication that we have of wait times across different countries. And we can see that Canada clearly ranks at the bottom whenever we look at most indicators of timely access to care. So when we look at the ability to get the same or next day appointment with a doctor or nurse in 2016, Canada, only 43% of patients were able to do that. In the Netherlands, the top performer, that number was 77. For the number of patients who had to wait for 4 hours or more in the emergency department, Canada again ranked right at the bottom, with 29% of Canadians having to wait 4 hours or more in the emergency department. But contrast that with countries like France and Germany, and that number is 1 and 3%, significantly less than Canada. When we look at the more common indicators, which are things like waited 4 weeks or longer to see a specialist, Canada again ranks right at the bottom with 56% of Canadians having waited 4 weeks or longer to see a specialist. Compare that to 22% in Switzerland and actually 24% in the United States, half of what's reported in Canada. And waited 4 months or longer for elective surgery. In Canada, that is 18%. In Germany, that's 0%. The United States is 3%. So when we look at wait times for care, that's clearly the area where Canada is a remarkably poor performer. It is, however, important, and we'll talk a little bit more about wait times because it really is what I call the defining feature of Canadian healthcare more than its, universal nature. We have to be very careful when we're looking at wait times from different countries. So while the Commonwealth Fund has one standard way of looking at it across these countries because it's looking at the percentage of patients as a survey, when it's actually tracked by different countries, this is just a slide to sort of say, be careful when quoting those wait times. Different countries do measure wait times in remarkably different ways. And in fact, in Canada, in particular, if you are quoting government websites, most government websites, until very, very recently, only measured the wait time between when a patient was listed and the beginning of treatment. And as you can see, that really missed a very, very large part of a patient's wait time journey. So in general, a lot of those websites are actually underestimating the true wait that patients face in Canada. What we've been doing at the Fraser Institute is we've been looking at the wait time between getting a referral from a general practitioner all the way to actually getting treated. So that's referral from a GP to seeing a specialist and then specialist to treatment. And that's actually the work that's done in our wait time survey, which interestingly, Professor Globerman actually started almost 30 years ago in 1990, 1991. And this really was the first comprehensive measurement of wait times in Canada in an environment where governments were essentially denying that wait times existed, and they could because there wasn't any data. So one of the things that we had to do was actually track how wait times, what wait times actually do look like every single year and how they've progressed. This is conducted on a national basis. It's sent to 10 different provinces. It looks at 12 different specialties. We now have a huge chronological timeline across 29 years. Each year we contact more than 10,000 physicians. We get responses from about 2,000 physicians for a response rate of about 17%. That might always seem small when you look at it as a percentage, but it's important to remember that this is actually the population of physicians in those specialties and not a sample. So it's actually 2,000 physicians who respond to the survey every year. There's a quick slide looking at what wait times look like in 1993 when the first national measurement was done. At that time, wait times were 9.3 weeks and caused a huge stir in Canada about how long wait times were. And our most recent survey in 2019 showed that wait times are actually 20.9 weeks, which has shown a steady deterioration in timely access to care in Canada. What the two bars show you are the two different parts of the patient journey. So you can see a pretty even split between the wait time from a general practitioner to a specialist, about 10.1 weeks, and then from specialist to treatment, which is about 10.8 weeks. Okay, this is showing what wait times look like across different provinces. And that's important because wait times are not consistently the same. Quite often we'll talk about provinces like Ontario and BC because they are Ontario, BC, and Quebec, they are the provinces that are well-known, have large populations, often talk about cities like Toronto and Vancouver. And as we can see, Ontario and Quebec actually have some of the shortest wait times in Canada. And I should say in Canada, because the wait time is still about 16 weeks on average in those two provinces, which is short in comparison to the other provinces in Canada. When you look at the Atlantic provinces like New Brunswick, Nova Scotia, and Prince Edward Island, wait times can go up to 40 weeks and 50 weeks on average. So significant differences across the provinces. There are also significant differences across the specialties, and this is what Professor Kloberman was alluding to earlier. Canada does have a triage system, so you will see shorter wait times, not small, but shorter wait times for things like radiation and medical oncology, where the average wait is about 4.5 weeks. But then you see much longer wait times for things like gynecology, ophthalmology, and general surgery. Orthopedic surgery has the longest wait time in Canada at 40 weeks. Essentially, it's a system where if you're in crisis mode, you will get taken care of, but everybody else has to face remarkably long waits. And I should mention that, some of these are remarkably important specialties and treatments. I mean, when you're looking at a 25-week wait for neurosurgery or a 39-week wait for orthopedic surgery, that's thinking of somebody who, is waiting for a hip and can't actually perform their job properly when it comes to orthopedic surgery, or neurosurgery when, it might actually be something that is eventually life-threatening. One of the things that the survey does and can help us confirm is that these wait times are also longer than what physicians in Canada consider to be clinically reasonable. So the red line is the actual wait time and the blue line is the clinically reasonable wait time. On average, we find that though the actual wait time between now just the second half of the journey, the specialist treatment journey, was 10.8 weeks, the median wait time was about 7. The reasonable wait time that physicians reported was about 7 weeks. So physicians themselves are telling us that the wait times that their patients face are about 3 weeks longer than what they consider to be clinically reasonable. Never mind what a patient might actually prefer if they could actually get treated on their timeline. And finally, it's important to note that although those were wait times for surgeries and procedures, there are also remarkably long wait times for diagnostic processes. So these are things like ultrasounds, 3.5 weeks, CT scans, almost 5 weeks, and MRIs, almost 10 weeks. So while Canada does have what may be called a functioning triage system, quite often it might take you 10 weeks to actually figure out and get that diagnosis to understand whether you actually have a critical condition or an elective condition, which can lead to a lot of situations where diseases can actually progress from a treatable illness to an untreatable and debilitating disease while you're still trying to get diagnosed for what's actually going on. Of course, all of these wait times have an economic cost. One of the things that the Fraser Institute does is we try to figure out what is the cost of the time lost as a result of these long wait times. Our estimate is that it was about 2.1 billion on the very conservative side in 2018. When we start to include things like hours during evenings and weekends, because they too have value, that goes up to about $5 to $6 billion. And of course, there are the traditional consequences of wait times that patients face. And these are things like pain and suffering, which are not actually well documented by governments or many organizations. There can be progressive degeneration, which is something we talked about. There are well documented cases of patients who are waiting far too long and have transitioned from something that might have been treatable to something that is now a permanent condition because they were not able to get treatment on time. And in the worst cases, there are instances where people can actually die while they're waiting for care. So it's not something to be simply brushed aside as a benign inconvenience. Wait times can and do have serious consequences for many patients. Okay, if we're okay on time, I'm just going to quickly brush through a little bit about pharmacare and the movements that are being taken over there. I'm not going to spend too much time on it, and if we have any questions, we can return back to it just to kind of keep us on track. Let me start by saying that, as you saw before, there's a lot of private activity in the pharmacare space. About 70.5% of Canadians have private insurance, most of which has to do with pharmaceutical care. However, a lot of times Canadian governments say that Canada is one of the only universal healthcare systems that doesn't provide pharmaceutical coverage. That, of course, is not true. Most provinces have safety nets for vulnerable populations. Approximately 21% of Canadians are taking advantage of those public safety nets. That being said, there are studies that say that approximately between 5 and 23% of Canadians are falling through the cracks and do struggle to pay for their prescription pharmaceutical costs. And this has really led to a brand new, well, not a new, but a long discussion that's kind of reaching a peak right now in terms of the implementation of a national pharmacare plan. The first steps, actually, let me just quickly mention 3 organizations that you should be aware about. Health Canada is the organization that is responsible for the regulatory review and approval of drugs. The PMPRB, the Patented Medicine Prices Review Board, sets the maximum allowable prices for all patented drugs in Canada, and is based on international and domestic reference prices. And there's another organization called CADIT, which makes recommendations for reimbursement for public plans in provinces. A lot of the changes that are being made right now are with the PMPRB, which sets those maximum allowable prices for patented drugs in Canada. Specifically, there's been a proposition over the last couple of years to remove the United States and Switzerland as part of the reference basket, and to replace them with Australia, Belgium, Japan, the Netherlands, Norway, South Korea, and Spain. The clear objective of this change has been to achieve lower costs by simply removing the United States and Switzerland. What's not talked about are the potential consequences, and the fact that 4 of the 6 new countries have lower rates of new drugs launched than Canada does. And there's also a move to really integrate CADIT in the future with the PMPRB by essentially having some form of cost effectiveness analysis in the PMPRB. What we've seen from CADIT is that essentially it leads to lower mandated drug prices to somewhere between 50 to 80% reduction in the price of drugs. So essentially, there's a lot going on right now to tweak the PMPRB and CADIT to mandate lower drug prices in the expectation that they're setting themselves up for a national pharmacare model. One political party is already committed to it, and the current federal government is weighing it very, very seriously as well. This is just a quick representation of what's actually the future under these propositions. The pie chart on the top looks at what the projection for private plans would be in 2027, given a status quo scenario, which would be about 38% of the market. If national pharmacare goes through, that red slice is going to go down to 7%. And these are not our estimates. These are actually estimates of the very people who are actually proposing the plan. Essentially, a new national plan would take over 80% of the pharmaceutical market, and private plans would be about 7%. So significant changes that are being advocated for on the horizon. Okay, so that's a quick talk about pharmacare, and I'm going to turn it over to Steve to give us a little bit of a wrap up with his discussion about legality and fairness and the advent of new technology.
Okay, thanks, Bacchus. So I'm going to just take a couple of minutes so we can move to the next slide. The Canadian system has specifically the restrictions on private payment have faced a couple of court challenges. There actually have been 4 court challenges, but I'm only going to mention 2. One was in 2005 and involved a patient in Quebec. And the challenge was that the patient was waiting excessively long, and the patient's charter rights, which is effectively the Bill of Rights that Canadians have, the charter rights were being violated by the waiting list. The Supreme Court of Canada basically said that if patients have to wait too long, it is a violation of their charter rights. And what was the response to this decision? The Quebec government allows private payment for some of the longest wait time procedures that Bacchus had mentioned earlier, in particular hip and knee replacements and cataract surgery. And the Quebec government acknowledged that it would have to put caps on waiting lists. But of course, that's determined by the province. Waiting too long is really, in a sense, a provincial judgment call. More recently, a case in British Columbia brought by Dr. Day, who operates a private surgery clinic, again brought this issue to the fore. When is waiting too long too long? And the court, in this case the BC Supreme Court, determined that, well, waiting is an issue, but more important is the sustainability of the public insurance system, and that private insurance or private payment out of pocket threatens the sustainability of the public system, and the public system, sustainability of the public system is the paramount concern of the government. And so, Bacchus, the next slide, please. Why does private insurance or out-of-pocket payment, why is this seen as being a threat to the public system, at least as far as some of the court decisions are concerned, and as far as many of the defenders of the Canadian system are concerned. Well, the notion is that if you have private payment allowed for medically necessary services, you're going to have a two-tier healthcare system. People who have money will get the care. People who don't have money will get either worse care or delayed care. And the notion is basically that private payment is going to crowd out public insurance in two ways. One, and this is important, one is that if people are paying privately, they may resist paying their taxes. That is, they may lobby politicians to drop the amount of public payment for insurance. But more importantly, that private insurance and private out-of-pocket payment will lead to a reallocation of inputs away from the delivery of service paid for by public insurance in favor of payment by private insurance. Next slide, please. Just very quickly, I've done some research on this. There's very little evidence of financial crowding out. The main concern is really that the private insurers, people paying out of pocket, will bid away the quote unquote good healthcare professionals, and therefore lead to slower delivery of service, lower quality delivery of service to those who are insured by the public insurer. And I'll just briefly say that we've done a lot of work at the Institute on this issue, and there really is no evidence to support those concerns. In fact, the evidence seems to be that wait times go down in the publicly insured system when you allow supplementary or complementary private insurance. And there's certainly no evidence that people who are insured under the public system get lower quality care. So let me finish up, Bacchus, with the next two slides. Can this system exist? Can the Canadian Healthcare Act effectively continue to prevent private insurance or private out-of-pocket payment for healthcare? There are two things that we've thought about, Bacchus and I have written a bit about. One is telemedicine. If people can go online and get their medical care, at least certainly diagnostic care, from anywhere in the world, how is the government going to prevent private payment? This is going to be a real challenge. And the second is personalized medicine. Bacchus mentioned earlier that there are really effective price controls on prescription drugs. And increasingly, personalized medicine is going to create opportunities for people to have access to life-saving drugs, which may not be paid for by the government Medicare system. What is going to stop people from going outside of Canada to get these life-saving drugs, but B, create enormous pressure, political pressure inside Canada to allow people to pay privately or to have insurance to access those drugs. Let's finish, Bacchus, with one last slide. And this is our overall summary of our talk today, which is Canada is an above average spender on healthcare, but certainly cannot be considered an above average performer. And in fact, I think the most generous summary you can say is that Canada's performance is mixed in terms of outcomes. It's probably below average in terms of access to healthcare resources, and it's absolutely the worst in terms of wait times. So that finishes what I think is our presentation for the morning.
That's great. Am I back on?
Yes, please proceed, Don.
Oh, great. Thank you. Well, thank you, Bacchus and Steve, for very exhaustive and wonderful insights on the Canadian system. I'm across the river from Canada, and I've appreciated learning a number of things that I wasn't aware of about the Canadian system. One thing I do want to ask before we get into the panel discussion, I want to remind attendees, if you wish to submit a question, please enter it in the Q&A section at the bottom of your screen, and we'll try to get as many as we can in the time remaining going forward here. But just let me clarify one thing, Bacchus. You said in the Canadian Health Act, the universality provision, you said that each province must provide care to all insured persons. Is there a distinction between residents and insured persons?
Well, the thing is, the insurance plan has to be provided to all residents.
Okay.
This has created some ambiguity when it comes to individuals like refugees or recent immigrants. But essentially, if you are a resident in the province and you have been here for 3 months, you are covered by, you either are covered by or you have to take up coverage with the provincial plan.
Got it. Okay, thank you. It's an issue in New York in terms of and in the U.S. about immigrants and undocumented immigrants, et cetera, in New York, and so that's why I wanted to make sure that we understood that distinction. Let's start with many times the Canadian healthcare system has been characterized as socialized medicine. Would you think that's an accurate characterization?
Well, I'll take a shot at that, Don. The short answer is no by the classical definition of socialism, which is where the government owns the means of production. Physicians and healthcare providers are private contractors who can choose to work or not. Hospitals, as Bacchus noted earlier, are they're not government owned, but the bulk of their budget comes from the government, and their activities are highly regulated under a general budget. So in the technical sense, no, but in the practical sense, for medically necessary services, the government is the large, essentially, director of how the resources are used and what they're used for.
Right, thank you. One question we have from a participant audience member here is, does your research touch on costs in Canada for particular hospital and physician services? Are there controls on prices like for drugs?
There's not a lot of research that we've done on that. What I can say is that the fees that physicians and hospitals get are negotiated with ministers and health associations in the province. So yeah, there are effective controls in terms of what their remuneration rate is, but it's not codified in the CHA first.
Great, thank you. A lot of the research here is about wait times. And can you talk about why the wait times are so much longer in Canada than in other countries characterized by universal health insurance coverage?
Sure, I can take that, and Steve can jump in if I miss something. We've done a lot of research in Canada. We really focus on Canada compared to other countries that have universal coverage, and that just helps us talk to Canadians about it, because then it's no longer a question about universal or not. But I think what a lot of Canadians are surprised to learn is that other universal healthcare countries do universal healthcare in a completely different way than Canada does. Our research generally finds three big differences between Canada and more successful universal healthcare countries. These are countries that, Switzerland, Sweden, the Netherlands, France, Germany, which generally have more resources and have remarkably shorter wait times. The first is their attitude towards the private sector. In Canada, the private sector is seen essentially as antithetical towards the notion of universal healthcare, whereas most of these other countries embrace the private sector either as a partner to deliver on the universal healthcare promise or as an alternative to act as a pressure valve when the public system can't cope with the demand for services. So completely different attitude towards the private sector. The second is that most of these other countries expect patients to share in the cost of treatment either as a percentage of the a percentage copay or an annual rate. Of course, all of them have annual caps to ensure that these are never financial burdens for vulnerable populations, but they all understand that these are important incentives to give and help people understand that these are scarce resources to be used responsibly. And the third is how these other countries fund their hospitals. Just about all the other countries that we're looking at fund their hospitals on the basis of activity. They use activity-basis funding, which essentially pays a hospital when a patient comes in. Whereas in Canada, we have these, as we said, predefined global budgets, which effectively lead to all the rationing that we see. So those are the three key differences that I've noticed. I don't know if there are any others that I missed out, Professor.
No, I think those are the main ones that we've identified.
Great, thank you. And just keeping on the wait time theme for a minute, the data that you present measures wait times from the point at which patients are diagnosed by their GP or family physician. Is it difficult for Canadians to access their own GPs?
Yes, that's become a growing issue, and Bacchus and I have written about that as well. Particularly, we're familiar with the situation in the province of British Columbia, where there have been long wait times to find GPs. The government, to its credit, has tried to develop a directory, an online directory to direct people to find GPs. But in fact, yes, indeed, it has been a problem.
Mm-hmm. One of the promises that advocates of the single payer in the US or in New York often make is that patients would be able to see any doctor of their choice. Is that the case in Canada? And are there limitations that the government sets over the specialist doctors patients can choose to see and when they might be able to see those specialists?
My research on this is more limited. My understanding essentially is that technically there aren't any limitations and restrictions, but from a practical sense, there are a lot of them. You can go and access any GP that you want, but again, you only get a family doctor if they are actually open to taking new patients. And then once you get that family doctor, because of the gatekeeping system, you get a referral to a particular specialist. Now, certainly you can try and see if there's a different specialist, you can talk to them and if they'll give you a different specialist. But usually what happens in Canada is everyone follows that one single path of you go to the available GP, you get the referral to whoever they consider is the right specialist, and that's the path that you follow.
Mm-hmm. Thanks. We have a question from the audience. Have you compared the Canadian health system to the UK health system in terms of costs and outcomes? And I think the question's maybe beyond, what the research you presented today.
Yeah, we've done. Sorry. So our larger comparison includes 27 other universal healthcare systems, and the UK is one of them for sure. It's neither a poor performer nor a top performer either. We haven't looked at it specifically because our focus has usually been on who the top performers are. And from our view, that's usually been, again, Switzerland, Sweden, the Netherlands, France, and Germany, which all have that very different approach. Just one quick note about the UK is that, even though, again, it's often classified as a purely public system, what's less talked about is that they actually have a robust private parallel healthcare system, which is actually unlike Canada. And in fact, in that particular way, it actually has more freedom for the private sector than Canada does, which is something that, even Canadians are not that aware about. So.
Yeah, interesting. And just keeping on the theme of the system and interaction with physicians, what restrictions, if there are any, does the Canadian health system place over how physicians may practice medicine?
I'll take that. It's a tough one to answer because there's so many different ways to do it. I suppose, one of the first ones are the rates and the way that physicians are educated in Canada and the availability of spaces. As you saw, Canada has one of the lowest ratios of physicians per capita. That's actually a government engineered problem. Canada actually had the average rate of physicians for a long time. And then in the early 1990s, the government essentially said, we have too many physicians, we're going to curtail some of the training, and Canada fell behind the rest of the world. That, of course, led to issues in terms of the secondary issues that when they actually graduate, when we started to ramp them up, a lot of the physicians could not actually find a position in a lot of hospitals. And that's indirectly because those hospitals are dictated by global budgets. So again, that's an imposition in terms of, well, okay, you graduate out of here, you can only get employment in a public hospital, and that was really dictated by what those hospitals are able to remunerate you to buy. And then the third one I suppose to bring up is that issue of dual practice, which is not explicitly required by the Canada Health Act, but everything in the Canada Health Act has led most, if not all, the provinces to either outright prohibit dual practice or to effectively disincentivize it to the extent that there are few to no physicians who have either opted out, and certainly few to no physicians who operate in both the private and the public sector. So those would be the sort of restrictions that come to my mind right at the beginning.
Well, thank you both very, very much for joining us today. I see that we're reached our time limit. I think this discussion could go on for days and weeks, maybe even, and we look forward to the opportunity to have you both back with us at a future time, because this topic is going to continue to be very, very important. So thank you again so much for sharing with us today. And I'll turn it back over to Eric to wrap us up.
Great. Thanks, Don, and Baucus and Steve. Thank you. And to just echo Don's point, we'd love to have you come back at a later date. I mean, the fact that we've got technology to be able to do this, we'll certainly be reaching out to you again. So this was a great conversation, a great discussion, really enlightening as to the shortcomings of the Canadian system and things for I think policymakers and others here in New York to really think about going forward.